So we are live now. So with all your due permission, I am beginning with the session for today.
Yeah, please start.
Yeah. A very good evening, everyone. Good evening to all. And I am Batul, the moderator for today's session. And I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our renowned stalwart who is present here with us today. Well, he is a very renowned pulmonologist, Professor Dr. B.N. Briem Prasad, sir. Sir is MD in Medicine, DNB in Medicine, DTCD, DNB in Respiratory Medicine, DM in Pulmonary Medicine, MNMS, European Diploma in Adult Respiratory Medicine, FICP, FNCCP, FCCP, USA, FRCP Glasgow, FRCP London, Senior Consultant at Pulmonary Medicine, Interventional Pulmonology. With Sleep Medicine, Chinmaya Mission Hospital, Bangalore. With such wonderful insights, we are going to talk about the topic, which is approach to management pulmonary hypertension. Now, without any further delay, I would like to welcome Sir at our forum. But before introducing him, I would like to just give you a brief about the topic. So in this depth exploration of the current approaches to managing pulmonary hypertension, this webinar will be covering essential topics, including diagnostic strategies, treatment options, and patient care pathways. Our expert who is here in the field will discuss the latest advancement in pharmacotherapy, surgical interventions, and lifestyle management aimed at improving outcomes and quality of life for patients with PH. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. So over to you.
Thank you for the wonderful introduction. Good evening, my dear doctors. The topic chosen today is approach to the management of pulmonary hypertension. We all know that there are two types of hypertension. One is systemic hypertension, other pulmonary hypertension. When there is elevated, persistent blood pressure in the pulmonary vasculature, so then it is pulmonary hypertension. When there is elevated pressure in the pulmonary vasculature, due to increase in the pulmonary vascular resistance, then that qualifies for the pulmonary hypertension. Similar to systemic hypertension, where there is persistent elevation of the blood pressure in the systemic circulation. You all know that pulmonary circulation is extremely important for oxygenation of blood and for removal of carbon dioxide. And the blood from the right heart moves to the left heart through the pulmonary circulation, where the oxygenation takes place, the diffusion of gases takes place in the alveolar capillary membrane, and the oxygenated blood goes back to the left side of the heart. The pulmonary circulation is essentially a low pressure, high volume circulation. So the pulmonary pressure is 1/5 of the systemic pressure. And it has got large number of capacitance vessels, so that during exercise and during stress, the entire circulation is occupied without increase in the pressure. So it has large reserve. And it is having thin wall and distensible. The pulmonary vascular resistance depends on the cardiac output, pulmonary artery pressure, and the left atrial pressure. The normal pulmonary artery pressure, as you know, is 25 by 8 millimeters of mercury. 25 systolic and 8 millimeters diastolic. And the mean pulmonary artery pressure is 15 plus minus 3 millimeters of mercury. So these are the fundamentals of pulmonary circulation. And this is a pictorial representation of the same, where you find that the right-sided pressures are higher than the left atrial pressure, and the blood from the right atrium, it goes into the pulmonary artery, from there to the pulmonary capillaries, then the pulmonary venules and the pulmonary veins, and then into the left side of the heart, left atrium. So there is various pressure gradients from the positive to the positive, but the left atrial pressure is lower than the right atrial pressure. Now, the pulmonary artery hypertension, as defined by WHO, is increase in the blood pressure in the pulmonary circulation, either in the arteries or in the arteries and veins. So we have pre-capillary and post-capillary, pulmonary hypertension. The normal pressure is, as I told you, 15 plus minus 3, that is 14, 18, whatever you can say, at rest. And on exercise, there is one slight increase in the pressure. So hemodynamically, it is defined as an increase in the mean pulmonary artery pressure. More than 25 millimeters of mercury at rest and 20 millimeter during right heart catheterization. When you do right heart catheterization, then you get the exact mean arterial pressure, and that is, if it is more than 20 millimeters mean pulmonary artery pressure, then it is pulmonary hypertension. Persistent elevation of the mean pulmonary artery pressure more than 20 millimeters of mercury amounts to the definition of pulmonary hypertension. So now we have pulmonary artery wet pressure. If you do Swan-Ganz catheterization and the floating balloon goes and occludes the pulmonary artery, and then that when you occlude it, it is in direct communication with the left atrium, and it signifies the left atrial pressure. And the pulmonary artery bed pressure, if it is less than 15 millimeters, then that is the pressure of the pre-capillary. And the pulmonary artery, and if the pulmonary artery the vascular resistance more than 3 Wood units, okay, then it implies that the patient has got the pre-capillary pulmonary hypertension. Now, if you do a Swan-Ganz catheterization, when you have the mean pulmonary artery pressure is more than 20 millimeters of mercury, and then if the pulmonary artery bed pressure is less than 15 millimeters of mercury, and then pulmonary vascular resistance is more than 3 Wood units, that implies that the patient has got a pre-capillary pulmonary hypertension. And the pulmonary vascular resistance is mean pulmonary artery pressure minus pulmonary artery bed pressure divided by cardiac output. And this can be assessed by fixed principle and by measuring the cardiac output and by the pressure gradient across, by which one can actually measure the pulmonary artery, the pulmonary vascular resistance. We call it as post-capillary pulmonary hypertension when the pulmonary artery bed pressure is more than 15 millimeters of mercury. So the previous definition, mean pulmonary artery pressure more than 30 millimeters of mercury with exercise, and the estimated systolic pulmonary artery pressure more than 40, all these things have not been accepted no longer. So we all know that we have WHO classification of 1 to 5 types of pulmonary hypertension. The pulmonary artery hypertension, idiopathic variety. Then 2 is pulmonary hypertension moving to left heart disease. Then pulmonary hypertension secondary to lung disease and chronic hypoxemia. And then 4th is thromboembolic disorders leading to pulmonary hypertension. And then miscellaneous, where we don't know the exact mechanism. So these are the various, the types of pulmonary hypertension. Type 1 is idiopathic, hereditary. There could be some genetic factors which could be responsible. Some markers of these genetic factors can be identified. Then some drugs and toxins can cause this problem. Then connective tissue disorders, particularly scleroderma. Then HIV infection. Then schistosomiasis. So all these things can lead to pulmonary hypertension. And then pulmonary hypertension which is responsive to calcium channel blockers. There are certain groups of pulmonary type 1 pulmonary hypertension which will respond to calcium channel blockers or prostacyclin agonists, the prostacyclin. So therefore, if they show a good response, that means the mortality, the outcomes, the morbidity is certainly better. So, those which respond to the calcium channel blockers, then pulmonary vascular veno-occlusive disease, then persistent pulmonary hypertension of newborn, and those who have a portal hypertension, they can have secondary pulmonary hypertension. So this comes under the classification of type 1, and so in familial, we know that bone marrow PR2, then ALK1, These are the markers which can be identified. Then connective tissue disorders, I told you, scleroderma, SLE, mixed connective tissue disorders, rheumatoid arthritis, congenital heart disease, certain types, portal hypertension, 5 to 7%, HIV, 0.5%, drugs like aminorex, appetite suppressants, dexphenphetamine, and then cocaine, methamphetamine, then hereditary hemorrhagic telangiectasia, hemoglobinopathies, myeloproliferative disorders, splenectomy, then venous and capillary involvement, veno-occlusive disease, evidence of pulmonary vascular congestion will be there if we do a CT scan, and then pulmonary capillary hemangiomatosis, and the persistent the pulmonary hypertension of the newborn. Now, the pulmonary hypertension due to left heart disease, there's a systolic dysfunction, there's a diastolic dysfunction, there could be valvular disease, and all this can lead to the pulmonary hypertension. It causes a post-capillary venous hypertension. Now, pulmonary hypertension associated with lung disease and hypoxemia. We all know that COPD is a very common problem, and as a pulmonologist, the progressive COPD can lead to pulmonary hypertension because of persistent hypoxemia in these cases. Even uncontrolled chronic asthma can have irreversibility, and then which can behave like COPD, and they can have pulmonary hypertension. Interstitial lung disease again can lead to chronic hypoxemia, and then the thickening of the aerocapillary septum, and as a result of which they can have pulmonary hypertension. Sleep disorder breathing, where you may not have a lung disease, they may not have hypoxemia due to lung disease, but they have a central hyperventilation, which can lead on to what is called, the pulmonary hypertension. Cellular hyperventilation disorders, chronic exposure to high altitude. Those people who live at a high altitude, height more than 9,000 feet above the sea level, those on the Tibetan plateau and all, they have for a long time, if they dwell, they can develop polycythemia, they can develop pulmonary hypertension. So it is some sort of a adaptation to the high altitude. And those people who are reinductees, they develop pulmonary hypertension, it can be progressive, and they may not tolerate this pulmonary hypertension, and they can develop serious consequences, like right heart failure and severe polycythemia, which can aggravate hypoxemia. Now, developmental anomalies can also, some of the developmental anomalies can come under the group 3 of pulmonary hypertension. Now, see, left heart disease, I've already told you, left ventricular ejection fraction may be preserved. They have a diastolic dysfunction, and they have a systolic dysfunction, and then they may have a reduced diastolic, left ventricular ejection fraction, and they have a heart failure with a preserved ejection fraction and reduced ejection fraction, and valvular heart disease, cardiovascular disease leading to post-capillary pulmonary hypertension. So we have certain groups of cardiovascular disease, heart failure, valvular heart disease, etc., which can lead to post-capillary pulmonary hypertension, something like a venous congestion, venous hypertension in these cases. Now, I have already told about the COPD and restrictive lung disease, obstructive lung disease like COPD, asthma, and then cystic fibrosis, and then, of course, bronchiolitis. Then restrictive, you know that ILD due to so many causes. Then those who have both mixed and obstructive pattern also. And then hypoxia with lung disease, without lung disease, hypoxemia in high altitude, etc. Developmental lung diseases, obstructive sleep apnea. And certain surveys show that it is not very uncommon. Even there could be mild to moderate elevation of the pulmonary hypertension in 15 to 20% among the people who have got obstructive sleep apnea. So, group 4 pulmonary hypertension, those who had acute pulmonary thromboembolism, and if they're not properly treated, and then later they can develop thromboembolic obstruction. And then repeated thromboembolic obstruction can occur in the proximal pulmonary artery if the clot is bigger. And then thromboembolic obstruction can occur in the distal pulmonary arteries. And so these are the causes of group 4 pulmonary hypertension. Then group 5, we have miscellaneous conditions where we don't know the exact mechanism. The mechanism is not very clear. So they have sarcoidosis, histiocytosis, LAM, lymphangioliomyomatosis, then adenopathy, tumors, fibrosing meningitis, thyroid disorders, glycogen storage disease, Gaucher's disease. So they can all cause the problem. And apart from the CTEPH, that is chronic thromboembolic pulmonary hypertension, pulmonary artery obstruction can occur due to angiosarcoma. Pulmonary arthritis, congenital obstruction can occur. There are some rare causes of type 4 pulmonary artery obstruction. Now, unclear mechanisms I've already told you. Remember that fibrosing alveolitis, portal hypertension, segmental pulmonary hypertension, chronic renal failure of patients can develop, tumor microangiopathy, thyroid disorders, Gaucher's, neurofibromatosis, glycogen storage disease, LAM. Occasionally, you may come across cases. Histiocytosis can occur. It is not very uncommon. Sarcoidosis, chronic sarcoidosis can lead to pulmonary hypertension. So they should be kept in mind. So certain hematological disorders can also lead to myeloproliferative disorders. Hematological disorders can lead to pulmonary hypertension. So this is again a representation. Pulmonary artery hypertension can be idiopathic, which is having a very bad prognosis. And then it's a progressive disease, common in females, 20 to 40. And heritable, I know certain markers will be there. Drugs and toxins, I've already told you, the weight reducing appetite suppressant agents, and then cocaine, amphetamine, connective tissue disorders, particularly scleroderma, HIV, portal hypertension, congenital heart disease, schistosomiasis is certain endemic areas in Mediterranean regions. Then one dash is pulmonary veno-occlusive disease, pulmonary capillary hemangiomatosis. And we have, the pulmonary hypertension due to left heart disease, I've already told you. Then pulmonary hypertension due to COPD and restrictive and obstructive, and then sleep disorders, yellow hyperventilation, high altitude, I've already told you. Then thromboembolic, I've already told you. Then multifactorial mechanism, hematological chronic hemolytic anemias, myeloproliferative disease, plenectomy, sarcoidosis, LAM, neurofibromatosis, vasculitis, glycogen, Gaucher's, thyroid disorders, tumor obstruction, fibrosing meningitis, chronic renal failure. Remember all these things. They can have pulmonary hypertension, which can lead to dyspnea, breathlessness, in addition to CRF, leading to a heart failure, and the pulmonary edema. Even pulmonary hypertension can also contribute to the worsening of dyspnea. So epidemiology, well, we don't have a detailed epidemiological studies. Some registries have been maintained in various countries, and these registries have been maintained in mostly in the European countries. And this is based on the European registry. About 15 to 10 cases occur annually, and prevalence is about 5 to 60 cases per million population. Per every million population, 15 to 10 cases occur annually, and prevalence is 5 to 16 cases per million. And among the connective tissue disorders has been found in 50% of cases. And scleroderma is the commonest cause. And scleroderma has got a very bad prognosis. But before therapy, the survival was only 2.8 years. And it is a progressive disease, the idiopathic one. And survival at 3 years was 72.9%. And there's a French study from 2006 to 2016. And chronic thromboembolic pulmonary hypertension, after acute pulmonary embolism, 0.426% can develop CTEPH. Surgery improves survival. This is one where the surgery can make a difference. And once you do the surgery, 80% survival versus 70% after surgery at 3 years. And the mortality and morbidity, of course, depends upon the preoperative function and comorbidity. They all have an important role in predicting the survival. Now, epidemiology, if you go, the commonest is idiopathic one, then connective tissue, then congenital heart disease, portal hypertension, appetite suppressants, HIV, familial. The familial is the lowest, HIV is next, appetite suppressants, and those are obese and all, they can have hyperventilation, And in addition, they are reducing the weight by using appetite suppressants like drug addicts, then portal hypertension. They can have secondary pulmonary hypertension. Then congenital heart disease, 11%. Connective tissue disorders, 15%. And the idiopathic occurs in about 39 to 40%. Now, we have to assess the risk. You see, all people who have mild pulmonary hypertension, they don't have a high risk of death and all. So, but then those who present with cardiac failure, if it is absent, that means there is a low risk. Because what happens, you all know that when there's a pulmonary hypertension, there is a pulmonary vascular resistance is increased, there's impedance of the flow, and therefore the right heart enlargement occurs, hypertrophy occurs, hyperplasia, hypertrophy, and dilatation occurs, and the heart failure occurs. So if they develop heart failure, JVP is raised, PLADM is there, and then in such cases, you know that they have a high risk of a poor outcome. Then if they have symptoms, but it is not so severe, they have the mild symptoms, but it's not progressive. Then if it is rapidly progressing, high risk, then if they get syncope, that means the cardiac output is low. And because hardly any output on the left side, because the hardly any flow because of pulmonary hypertension, right heart failure. So then it is associated with high risk. Those New York Heart Association, class 1 to class 4, they are absolutely fine. They are not symptomatic. They get symptoms on very severe exertion. And then those who get symptoms on moderate exertion, class 2, who get symptoms on mild exertions also, and who are symptomatic even at rest. So that is New York Heart Association dyspnea symptom scoring. Then 6 minutes walking test, you ask the patient to do 6 minutes walking, and how much distance is covered. If they cover more than 440 meters, and that means it is a good indication that the patient does not have a serious risk factor. It's a low risk. If you do cardiopulmonary exercise testing, what is the VO2 max? That is the maximum oxygen consumption. You see, normally the oxygen consumption should be of 15 to 20 ml. And if it is more than 15 to 20 ml, that means it is normal. When the oxygen consumption decreases, and they're going to go for the anaerobic metabolism, and then what happens in such cases? So the VO2 max decreases, and then here when it is between 11 and 15, then the risk factor is about 35 to 68%. Then the high risk is when you have the VO2 max is less than 11 ml per minute per kg body weight. So when you do cardiopulmonary exercise testing, you measure the VO2 max, and if the VO2 max is more than 15 ml, that indicates that there is a low risk. If it is reduced and between 11 and 15, you have intermediate risk, and if it's less than 11, it is a high risk. Then NT-proBNP, which is a function of the right heart, the heart status. Now, if it's less than 50 nanogram, at the low risk, if it is between 50 to 300 nanograms per liter, then it is intermediate risk, and it's more than 300, that means there's a high risk. And if you do echocardiography, EMR, right, you can measure the right atrial area. If it's less than 18 centimeters, low risk. If it's 18 to 26, there's intermediate risk, and more than 26, that is what you call the high risk. If you do hemodynamics and you measure the right atrial pressure is less than 8 millimeters, it is a low risk. 8 to 14, it is intermediate, and more than 14 millimeters of mercury in the right atrial pressure, that means it is a high risk. So the pathogenesis of pulmonary hypertension, you see, we all know that there could be risk factors. So congenital heart disease, portal hypertension, HIV, drugs, toxins, pregnancy. and then there's a susceptibility, genetic factors may be operating here. Then it also leads to endothelial dysfunction. So when there is endothelial dysfunction, there is a decrease in the vasodilatory substances like nitric oxide, prostacyclins, and the vasoconstrictor substances will increase, thromboxane, and then endothelin 1 production increases. Then there is also the vascular smooth muscle relaxation potential also goes down, and there is impairment in the voltage gated potassium channels also. And then there is a hypertrophy and hyperplasia of these muscles. And then what happens that then there is a plexiform lesions also can occur. So there is a combination. There is endothelial dysfunction, then the permanent changes can occur in the pulmonary vessel itself, and then there is hypertrophy, hyperplasia of the smooth muscles, intimal thickening can occur, adventitial thickening can occur, and then of course there could be mild thrombus formation, new vessels can form, plexiform lesions can occur. So all this leads to the pulmonary obstruction. Now, so endothelial pathways, you know that we have different pathways, nitric oxide pathways, the prostacyclin pathway, endothelin pathway. So fundamentally, they are all important in vasodilatation and vasoconstriction. So the pro-endothelin production, endothelin receptor A is there, endothelin 1 and 2, and then there's stimulation of this endothelin 1, then there's a vasoconstriction and proliferation. And then what happens that the smooth muscles are also activated. There's hypertrophy and hyperplasia. Then nitric oxide pathway, they have L-argine, L-citrulline, then nitric oxide production. Then there is a balance between GMP and AMP, and phosphodiesterase pathways is also involved. Phosphodiesterase inhibitors can also increase the cyclic GMP, and exogenous nitric oxide. So when there is nitric oxide, this one, what happens? There is a vasodilatory response. Now, prostacyclin, again, they give the prostacyclin, cyclin level increases. What happens that you have basically vasodilatory effect, and so otherwise you will have a vasoconstrictory response. So depending upon which type of prostaglandin is released in the arachidonic acid pathway. Now, in idiopathic variety, we exactly don't know the cause. Therefore, it is called the idiopathic. There are multiple factors. They have an excessive vasoconstriction to a minor stimuli, abnormal function, expression of potassium channel, smooth muscle cells, endothelial dysfunction, impaired production of vasodilator and vasoconstrictor substances, nitric oxide, prostacyclin, thromboxane A2 is a vasoconstrictor. So endothelial 1 is a vasoconstrictor. So then, as I told you, medial tunica hypertrophy of smooth muscles, intimal proliferation thickening occurs, fibrotic changes occurs in the tunica intima, intimal thickening, concentric and eccentric thickening can occur, adventitial thickening occur, and there's a perivascular infiltrates, and you can have a complex lesions like plexiform lesions, dilated lesions. They're non-functional, they're dilated, non-functional. Okay, there's a stagnation of blood, and thrombotic lesions. So when there's stagnation of blood, also you find the thrombosis can take place. So left heart dysfunction, as I told you, there's a back pressure, the venous hypertension occurs. So that occurs in a group 2 pulmonary hypertension. Now, group 3, multiple factors. COPD, airway obstruction, hypoxia, ventilation, perfusion mismatch. There is a air trapping, hyperinflation, compression of the pulmonary capillaries and pulmonary veins because of the hyperinflated lung and air trapping there. And over a period of time in emphysema, there is a loss of capillaries also. And in fibrosis, again, there is the capillary volume decreases. Then inflammation, arthritis, capillaritis, toxic effects of cigarette smoking, vasoconstriction, then endothelial dysfunctions, All these things can lead to pulmonary hypertension in a setting of hypoxemia or due to airway hyperventilation, secondary to lung disease or central hyperventilation syndromes or high altitude exposure of a chronic nature. Now, this is smoking, vasoconstriction, inflammation, TNF, alpha, TGF is increased, proliferate endothelial 1, vascular growth factors, then decrease in those cells which produces vasodilating substances, apoptosis of this nitric oxide production and prostacyclin, vascular compression due to airflow obstruction. So all this can. Then, so when the CTE appears, there's a non-resolution acute embolic masses, fibrosis occurs. So there is a mechanical obstruction. So then we don't know exact mechanism. Multiple factors may be there. Alteration in the pH, alteration in the endothelial functions, and then the production of the vasodilators, the vasoconstrictions, or there's an infiltration because of the certain disease, like Gaucher's disease, and these things, and thyroid disorders again, where there could be infiltration of these blood vessels, thickening of these connective tissues can occur. So all this can lead to pulmonary hypertension in thyroid. Mediastinitis, fibrosing mediastinitis, again, that could be compression and obliteration. So myeloproliferative disorders, again, there could be some infiltration with the cells, and then the cell mass index increases in the pulmonary vasculature, which leads to pulmonary hypertension. So there are the multiple factors which operates in a case of a type group 5 pulmonary hypertension. So drugs, again, definitive we know aminorex, fenfluramine, toxic rapeseed oil. In certain rapeseed oil, there was Spanish toxic oil. In certain areas it was reported. Then benfluorex, then cocaine, phenylpropanolamine, St. John's wort, chemotherapeutic. These are all in drug addicts. Chemotherapeutic agents. Some chemotherapeutic agents can lead to pulmonary hypertension. Then pergolide and all those things, which can lead to selective serotonin reuptake inhibitors. And these drugs are used in treatment of Parkinson's disease. Now, amphetamine, L-tryptophan, methamphetamines, oral contraceptives, which can cause pulmonary hypertension. Pregnancy can worsen pulmonary hypertension. So please, the hormones can have a role in pulmonary hypertension. Oral contraceptives, estrogen, cigarette smoking. So these are all things which has to be kept in mind while treating the patients with pulmonary hypertension. Now, the most important, the hallmark feature of pulmonary hypertension is breathlessness. Dyspnea. So unexplained dyspnea. You did all the tests, but you are not able to find out what is the cause of this. It could be idiopathic pulmonary hypertension. Heart is okay, lungs are okay, everything's okay, no the connective tissue disorder. But then those which are secondary hypertension, due to connective tissue disorders, we all know CREST phenomena. CREST is there, calcinosis, Raynaud's phenomenon. Telangiectasia, yes. So look for Raynaud's phenomena, that is warming, cyanosis, on exposure to cold, swelling, pain in the distal parts of the hand. Then, of course, liver disease, portal hypertension, HIV, sickle cell disease, then obstructive sleep apnea, family history. Some families, there will be history. Family history is there. In familial, this one, you will find some markers of that. Then those who have obese and use stimulants and anorexigens uses, etc. So this is what we have to, whenever we take the history, you suspect pulmonary hypertension who have unexplained dyspnea. Now, dyspnea is the most important because, and then they get fatigue, easy fatigability. When the cardiac output is low, they get syncope also. And chest pain because of enlargement of pulmonary artery, and also ischemia because of low cardiac output. Palpitation can occur because right atrial, left atrial enlargement can lead to, the conduction defects. They can have, the atrial fibrillations, and they can have various types of conduction defects. Then you can have edema, right heart failure. Hoarseness of voice can occur because of the left atrial enlargement and recurrent laryngeal nerve can be obstructed, and therefore it is called the Ortner syndrome. So they can have hoarseness of voice. So when you do the physical examination, you look at the jugular venous pulse, prominent V waves may be there because of tricuspid regurgitation. The lungs could be clear, or you could have features of COPD, or you have features of chronic asthma. Then the fixed splitting of left, there is parasternal heave, then a loud P2, fixed splitting. There is no change during inspiration and expiration. And you have a large pulsatile liver. Then cold extremities because of decreased cardiac output. Clubbing can be there. And there will be peripheral edema. So, diagnostic workup, suspect pulmonary hypertension, echocardiography, suspect pulmonary hypertension, low clinical suspicion for a pulmonary hypertension, yes or no? If it is yes, then seek for alternative diagnosis. So you do an echocardiography, there is a pulmonary hypertension, then you find out the etiology, low clinical suspicion for pulmonary hypertension, seek for alternative cause of symptoms. Okay, now if there is a pulmonary hypertension on the echocardiography and you do an exercise echocardiography, right heart catheterization to confirm the pulmonary hypertension, and there's a significant left atrial disease adequate to explain pulmonary hypertension, then it is group 2. And if it's not able to explain, then we have to think of the COPD and heart conditions, the lung conditions. PFT should be done, overnight oximetry, or the sleep studies, polysomnography, ventilation perfusion scan, if there is a thromboembolism, ANA, the rheumatoid factor, ANCA. This is if you are suspecting connective tissue disorders, HIV serology, liver function tests, they have to be done. Then underlying cause of pulmonary hypertension still not identified. It could be idiopathic pulmonary artery hypertension. Then it could be if underlying cause of pulmonary hypertension is identified, then it could be group 1 again, veno-occlusive disease, etc. And then it could be group 3 also. It could be group 4 and group 5. And then confirm the diagnosis by right heart catheterization. So this is what you're supposed to do. So first, you have to, the patient has got the symptoms of breathlessness, chest pain, syncope, pedal edema. Those features will be there. Then once you know that, then you do an echocardiography. It shows that the patient has got pulmonary hypertension. It will also identify whether there's a right heart problem, left heart problem, whether there's a congenital heart disease or acquired heart disease, whether the diastolic function, systolic dysfunction. Those things can be identified. And when we are not able to identify the heart is okay, the cause of pulmonary hypertension could be still idiopathic, or it could be secondary to the, it could be thromboembolic. And then, of course, it could be because of group 3 causes, and then miscellaneous causes, group 5. So we have to do autoimmune serologies, liver function, portal hypertension, etc., HIV serology. So then autoimmune, these things should be done. And then if you do a chest X-ray in these cases, it indicates that there's a pulmonary hypertension. There is enlargement of the central pulmonary artery. The hilum appears prominent. Right ventricular hypertrophy will be there. Then there is pruning of the blood vessels. You find the distal, there's hardly any vasculature. It appears, black. Okay. Then, so clear lung fields peripherally. Centrally, you find the prominent vasculature and right heart enlargement. So that is a feature on chest X-ray. Now, if you do ECG, right ventricular hypertrophy, right axis deviation, R wave S wave ratio greater than 1 in lead V1. So incomplete or complete right band block. Increased P wave amplitude in lead 3, pre-pulmonary due to right atrial enlargement. Then echocardiography. So screening when clinical suspicion exists. Standard interval screening at selected groups. Then you have to do periodic echocardiography in selected groups as a follow-up. Those who got idiopathic pulmonary hypertension with a known bone marrow PR2 mutation, scleroderma spectrum, pre-liver transplant. So here the serial echocardiogram may have to be done. Now, when you do echocardiogram, you will have tricuspid regurgitation, right atrial and ventricular hypertrophy, flattening of the interventricular septum. Actually, it will push to the left side. And small LV dimensions and dilated pulmonary artery. Pericardial effusion is a very poor prognostic sign. Right atrial pressure so high. I told you, when you do 14 millimeter is still higher, then it is a very poor prognosis. It should be less than 8. 8 to 14, intermediate risk, and more than 14. Right atrial pressure so high it impedes normal drainage from pericardium. Okay. Do not drain usually does not induce tamponade since RV under high pressure and non-collapsible. So therefore, it is not like a tamponade. So that you have to do the drainage of the pericardial effusion. Now, you can do grading, systolic 30 to 50, mild, diastolic 20 to 25, mild, mean 30, then grade 2, 50 to 70 systolic, diastolic 26 to 35, mean pulmonary arterial pressure more than 40, grade 3, severe 70 to 110 systolic is almost like systemic pressure, diastolic 36 to 45, and mean is more than 50. When grade 4 is systemic or suprasystemic, when the systolic pressure of the pulmonary vessels is 110, diastolic 46 to 55, mean is more than 60. So that is very severe form. Right heart catheterization, right atrium less than 6, right ventricular less than 30/6, that is the pressure. Then pulmonary artery less than 30/12, pulmonary capillary blood pressure less than 12. Then pulmonary vascular resistance you measure, cardiac output by fixed principle. Pulmonary vascular resistance is measured by 80 into mean pulmonary artery pressure. So that is to conversion of Wood units into dynes. Therefore, you actually multiply by 80. So mean pulmonary artery pressure minus left atrial pressure divided by pulmonary blood flow. That is, so you do the cardiac output is measured by arteriovenous oxygen difference, and then the fixed principle is estimated oxygen consumption and arteriovenous oxygen difference. So at catheterization, you take various samples and then do this cardiac output studies. And also you measure the pressures, right atrial pressure, right ventricular pressure, pulmonary arterial pressure, pulmonary capillary blood pressure. So then that is a sure gold standard for diagnosing pulmonary hypertension. Now, so this is again the depistation. So pulmonary vascular resistance is more than 240 dynes. If it is Wood units, then you have to, that is more than 3 Wood units. 80 into 3 is 240. 3 Wood units is converted for conversion into dynes centimeter per second. This one you have to multiply by 80. So, whenever you have a pulmonary hypertension, please rule out chronic thromboembolic pulmonary hypertension. This is often missed. The patient had some acute onset of breathlessness, had a pulmonary thromboembolism. It was not life-threatening. There have some blockages occurred, and it went undiagnosed. Our patient had a pulmonary thromboembolism, has recovered, and there was no follow-up study in these cases. The patient did not receive long-term anticoagulants or thrombolytic agents. so anticoagulants, and therefore, again, there could be recurrence. And there could be certain conditions where there could be thrombotic factors, maybe they have an operation, they may get recurrent small emboli. So, many times, this diagnosis may be missed. Okay, so therefore, please exclude in every case chronic thromboembolic pulmonary hypertension because it can be treated. If there is a proximal large obstruction, you do endarterectomy and the patient improves. So the most important study that you have to do is VQ scan. Okay, and pulmonary angiography, CT pulmonary angiography. Okay. Now, as I told you, there are certain types of pulmonary hypertension which respond to calcium channel blockers and also inhaled nitric oxide. So they have a better response and a better outcome. So inhaled nitric oxide, you do prostacyclin, iloprost, IV, and then or in nebulized form. And so it is a preferential pulmonary artery vasodilator. And then at cardiac catheterization, you find the mean pulmonary artery pressure decreases by 10 millimeters and to a value less than 40 millimeters. That means it's a good response, good response. When the mean pulmonary artery pressure is more than 20, we call it pulmonary hypertension. We call it, moderate to severe when the mean artery pressure, goes more than 40 and higher. So, when you give this nitric oxide, inhaled nitric oxide, or this prostacyclins, what happens that if the mean pulmonary artery pressure decreases by 10 millimeters and the value less than 40 millimeters, then it is positive. And there is associated increase in the cardiac output. The cardiac output may not increase, but it does not decrease. And minimally reduce or unchanged systemic blood pressure. So that means it is a good response. Only patients positive vasodilator are given treatment with calcium channel blockers. Calcium channel blockers like isoptine, then nifedipine and all, they have to be given a very high dose, not the conventional dose. So it can produce a lot of problems. So this should be given only who have a positive vasoreactive testing with inhaled nitric oxide or prostacyclin, iloprost. Now, survival, is it progressive symptoms? Is there a heart failure? Is the BNP levels high? Which I've already told you. So the prognosis, idiopathic is very poor. Median survival, I already told you. And then those who have scleroderma, again, it has got a bad prognosis. Now, those who have a good 6 minutes walking test, that means they have got a better survival outcome. Those who have the 6 minutes walking distance is less, they have a poor outcome. So this is a very important test, 6 minutes walk test, which requires a clock and a corridor. It is a very simple test. You don't have to do echo and all. You just do a simple 6 minutes walking test. And if they are not able to cover the distance, then it has got poor prognosis. Now, so the poor prognosis factors, age, then those who have class 3 or class 4 WHO symptoms, NYHA, failure to improve to a lower WHO functional status during treatment. If you do treatment, they don't respond. Echocardiac findings of pericardial effusion, large right atrium, I told you more than 14 millimeters, elevated right atrial pressure. Okay, septal shift to the left, and decreased pulmonary artery capacitance vessels, stroke volume, etc. Then BNP is rise. Then QRS duration is increased. QT interval QRS duration increase. Heart blocks, hypocapnia. Okay, comorbid conditions like COPD, diabetes, etc. They all have poor prognosis. This is again, I told you the New York Heart Association functional classification, no symptoms with ordinary physical activity, but when you do severe exertion, you will find symptomatic. Then you get symptoms on mild ordinary activities, slight limitation activities there, but otherwise they are able to carry out the activities, routine activities. But with the less than ordinary activity, they feel symptomatic class 3. These are the ones who have got a bad prognosis. And then class 4 symptoms are the ones who are restricted to bed only, or even at rest also, they are symptomatic. Now, so how we treat them? So if pregnancy will aggravate it, avoid pregnancy. Contraception, if it is required, imperative. Contraception itself can lead to, what you call the pulmonary hypertension. Maternal mortality, 30% if the pregnancy continues. And immunization for respiratory illnesses. If they have COPD and they have other respiratory disorders, if they get pneumonia, it becomes worse because of hypoxemia. So immunization with influenza, with pneumonia, herpes, and then we have got respiratory syncytial virus. This is adult immunization can be done. Then minimize Valsalva maneuvers, because when you do respiratory maneuvers, the intrathoracic pressure increases, there is decreased cardiac output, and the result of which they can develop syncope. So when there's constipation, when there's severe cough, weightlifting, heavy lifting, etc. So with the breath hold, it can lead to the person may collapse. So one should avoid this. We have classes of therapy. When there's a right heart failure, you have to give diuretics. Then anticoagulants should be given when there is chronic thromboembolic pulmonary hypertension. Digoxin can be given, there's a heart failure. Oxygen has to be given because they have hypoxemia. And then we have got, these are the general measures. Then pulmonary artery hypertension specific therapies are there. They are basically endothelium, which acts on the endothelium one, vasodilators. And then we have surgical therapy, atrial septostomy can be done as a bridging before we go in for the heart lung transplantation. So these are the surgical options. Then you have chronic pulmonary thromboembolic pulmonary hypertension, endarterectomy can be done in some of the cases. Now, diuretics you all know for treatment of right heart failure, thiazides and loop diuretics need to be used. And we should be very careful, because if you decrease the preload, then cardiac output decreases. So, and over a period of time, they may require large doses of diuretics. Anticoagulants will benefit in some cases of idiopathic pulmonary hypertension because they have an in situ thrombosis. So, in other groups, we are not very sure whether they should be given. Okay. But when we use these anticoagulants, keep generally between INR 2 to 2.5. Okay. So this is the prophylactic anticoagulants. Now, oxygen, we have to keep the oxygen saturation more than 90%. And if there's hyperventilation syndromes and all these things, you may have to do CPAP therapy also. And COPD in addition to oxygen, we have to give for controlling the hyperventilation, the BiPAP therapy. If you just give oxygen, then there could be depression of the ventilator drive, and they can develop hypercapnia, and they can become unconscious. So in case of COPD patients who have advanced COPD and retention of carbon dioxide, so in such cases, in addition to oxygen, we have to give BiPAP. That is non-invasive ventilation to remove carbon dioxide. Now, we have pH-specific therapies. We have calcium channel blockers, which are responding to the, at cardiac catheterization, radar catheterization. You give them nitric oxide, and if they show good response with a decrease in the mean pulmonary artery pressure, to less than 40 millimeters, and then 10 millimeter decrease is there, and the cardiac output marginally improves. So in such cases, you give high dose of calcium channel blockers like nifedipine or isoptin. Then endothelin receptor antagonists, we all know we have different groups of that: bosentan, citaxentan, ambrisentan. Then we have phosphodiesterase inhibitors, sildenafil, tadalafil, vardenafil, etc. And they are most commonly used in COPD patients who have pulmonary hypertension. And so prostanoids, we have epoprostenol and treprostinil and iloprost. These are the ones which can be given. Some prostacyclin agonists are there. We have what is selexipag, and this is the one which can be given orally also. So selexipag is the one which can be given orally. You have to give high doses. Start with 200 milligram BD dose and gradually increase. But when you give high doses, you have to be careful about the renal functions and the liver functions. If the liver function is okay and there's not, then you can give higher dose. And so it should be gradually increased. Carnylate cyclostimulant again is some sort of vasodilator which has got a role. Ryosi growth is used in chronic pulmonary thromboembolic pulmonary hypertension. Most of these drugs, like calcium channel blockers, endothelin receptor antagonists, phosphodiesterase inhibitors, they have been used in various combinations in the treatment of idiopathic pulmonary hypertension. Okay, so they are used, but the secondary causes should be treated. With the secondary causes, they should be treated. Primarily, they should be treated. In addition, you give these pulmonary, vasodilators and those which inhibit the vasoconstriction. Now, so we all know the endothelin pathway, endothelin receptor antagonists. We have bosentan, citaxentan, ambrisentan. pH treatment, nitric oxide pathway, phosphodiesterase inhibitors, sildenafil and tadalafil. Prostacyclin pathway, epoprostenol, treprostinil, then miraprost, inhaled iloprost, intravenous iloprost is available. Then I told you selexipag. So then calcium channel blockers, we have diltiazem, nifedipine, then titrate up to maximum tolerated dose. Systemic hypertension may prohibit use. Only 50% patients maintain response to calcium channel blockers. So then endothelin receptor antagonist targets relative excess of endothelin 1 by blocking the receptors on endothelium and vascular smooth muscles. Endothelin 1 receptor blockade leads to is achieved by bosentan, ambrisentan, citaxentan, macitentan. Okay. Ambrisentan is a endothelin A selective. Both show improvement in 6 minutes walking test, time to clinical worsening. Monthly transaminase liver function has to be done, as I told you. Annual cost could be high. Now, so liver function is very important. If they have a moderate liver dysfunction, serious dysfunction, you should not use it. When you use it a long time, it can lead to cirrhosis, etc., unexplained hepatic cirrhosis, rare cases. Now, initiate 62.5 milligram BID for 4 weeks, then increase the dose, 125 milligram BID in addition. So, these drugs can be given. Then, of course, we have the latest drugs also become available. We have ambrisentan 5 to 10 milligram tablets are available, which can be given on daily dose. Macitentan 10 milligram tablets is also available. And OD dose can be given. So instead of bosentan. Now, ambrisentan, as I told you, 5 or 10 milligram dose can be given, and that is available in our setting also. So there's a much less risk of transaminase elevation. No dose adjustment is required when you have to use warfarin. Then phosphodiesterase 5 inhibitors, nitric oxide excess effects to the cyclic GMP, which I've already told you, and is modulated by phosphodiesterase E5 inhibitors. So the basically nitric oxide increases the level of cyclic GMP, and so then there's decrease in the intracellular calcium, and there's relaxation of the smooth muscles. So the vasculature has got PDE5, and these PDE5 inhibitors can, like a sildenafil and tadalafil, and all these things will have, uh, and vasodilatory effect. So sildenafil has, it causes flushing, epistaxis, headache, sudden hearing loss can be occur. So you can use 20 milligram TID dose, tadalafil 40 milligram body, vardenafil 5 milligram body. So this is the dosage. Prostacyclin analogs, we have, Ryosi. So this is the one which is available as a 0.5 and 1.5 milligram tablet. Otherwise, we have inhaled prostacyclins, and also we have IV prostacyclins. Epoprostenol, treprostinil, iloprost, they have to be given very high doses, intravenous or oral. Vasodilatation, platelet inhibition, anti-proliferative effects, inotrophic effects. They have got multiple effects. Epoprostenol, it was a specific therapy available from mid-90s. Lack of vasodilator response does not correlate well with epoprostenol, and very short half-life, delivered via continuous infusion. Cost is very high. So, side effects, headache, jaw pain, flushing, diarrhea, etc. So, now we have oral drugs now, as I told you, Celipeg, Celixipag, 200, 400 milligram microgram tablets are available. You give a starting dose of 200 milligram BD weekly, then increase the dose to 400 milligram BD, 800 milligram BD, then 1200 milligram BD, 1600 milligram BD. That's the maximum dose. And then, of course, you have to be very careful about the liver and the renal functions. And so, and the ibuprostenol, they are all given while testing, of course, doing catheterization, otherwise by continuous infusion. So, inhaled prostacyclins are available, which can be used. Iloprost is inhaled prostacyclin. 6 to 9 times should be given via specialized nebulizer. You can get syncope. That is one of the side effects of iloprost. So it improves the 6 minutes walking, functional stars, hemodynamic absorb. It has got a hypotensive effect with other antihypertensives, increases the bleeding, especially with the co-administrative anticoagulants like warfarin, and then flushing, increased cough, headache, insomnia, nausea, vomiting, flu-like symptoms, increased liver enzymes. So these are the problems of prostacyclins. Guanylate cyclase inhibitor, Ryosigot, which I told you, 0.5, 1 or 1.5 milligram oral stimulant has reported benefit patients with inoperable, persistent, chronic thromboembolic pulmonary hypertension. So this is selectively used in chronic thromboembolic pulmonary hypertension, which are inoperable, persistent pulmonary hypertension. So there are various studies, large controlled studies which have taken place. They combined with the single and the combination of bosentan and phosphodiesterase inhibitors, and they find that definitely there is a benefit in terms of 6 minutes walking test and the patient symptomatic improvement. So this is again a representation of the various drugs which acts. Vasodilator therapies, we have calcium channel blockers, we have androgen receptor antagonists. Then, of course, we have the prostacyclin, the agonists, nitric oxide release drugs. And then we have inhalation therapies, we have intravenous therapies. Then, of course, so we have various, the pharmacotherapies which have come into play and which have made a difference in the quality of life of the patients with the pulmonary hypertension. Now, when there is a failure of medical therapy, you have to consider atrial septoplasty. Now, improved left-sided filling, decreased right-sided pressure, may serve as a bridge to the transplant. So that is the one last resort one may have to do in selected cases who are likely to have a lung transplantation. Now, when there is a failure of medical therapy, then we have to go for the last resort, lung transplantation. That means who have a class 4 symptoms. Mean right atrial pressure more than 10 millimeters of mercury. Mean pulmonary artery pressure more than 50. Failure to improve functionally despite optimal medical therapy. And there is a rapid progression of the disease. So then we have to go for the lung transplantation, my dear doctors. So I've covered all these things. I don't want to repeat again and again. So, following responsive therapy, as I told you, 6 minutes walk test, echocardiography, right heart catheterization, BMP levels, function class. So this is what has to be monitored. So we have to a specialized pulmonary hypertension clinic so that you can go in for all these aspects. Once you know that they have a pulmonary hypertension and they have an advanced disease, it is better that these cases are managed by experts in the pulmonary hypertension clinic and where they can assess all aspects of the pulmonary hypertension. They can assess the pulmonary, they can the rehabilitation program, they can have certain preventive strategies. Then, of course, they can optimize the pharmacotherapy. Then they can select some of the cases for the heart lung transplantation. So, therefore, the follow-up of these cases is extremely important. And those cases who have, chronic thromboembolic pulmonary hypertension with the proximal artery obstruction, then these cases one can go for endarterectomy, and that should be done. Okay, for that we have to do V2 studies. So, my dear doctors, in the given time, I try to cover most of the pulmonary hypertension, group 1 to group 5. I try to explain to you the pathogenesis and the hemodynamics of pulmonary hypertension. When there is a pulmonary hypertension, is secondary to the increase in the pulmonary vascular resistance. The pulmonary vascular resistance is basically because of the changes which take place in the pulmonary vasculature, and these changes can be endothelial dysfunction, an imbalance of the vasodilators and the vasoconstrictors. There is also certain permanent structural changes can take place. That is the hypertrophy and the hyperplasia of the muscles. Then there is a fibrous tissue formation in the adventitia and also in the intima. And then the vascular occlusion can take place. Then the vessels can get dilated and thrombus can occur. You can have plexiform lesions. So then, of course, if there is pulmonary venous hypertension, it gives a clue that the problem can be in the heart, left side of the heart, diastolic or systolic dysfunction, valvular heart disease. And if there is a venous congestion on CT scan, it indicates it could be veno-occlusive disease. So these are certain features one can identify by CT scan. And if you do a CT scan, you may find also some thromboembolic occlusion. Okay, so and then echo will also give us a lot of information. Then we have various markers for connective tissue disorders. We have for HIV, we know the investigation, HIV testing has to be done. So in secondary causes can be identified. In some cases, if there are obese people and drug addicts or who are on, immunosuppressants, the appetite suppressants, then that could be the cause of pulmonary hypertension. COPD, smokers, and hyperventilation, sleep apnea should not be missed, and thromboembolic episodes should not be missed. So, idiopathic is the one which carries very poor prognosis, and idiopathic is one is very rare, but it carries poor prognosis. It occurs in middle-aged ladies, not middle-aged, 40 to 20 to 40, and it can be progressive. Hormones also play an important role. Oral contraceptive pregnancy can aggravate it. Then Then we know that those who respond to the calcium channel blockers, so that should be identified by cardiac catheterization and giving nitric oxide and see whether there is a vasodilator response. Then, of course, we have chronic thromboembolic pulmonary hypertension should be excluded, and endotheliectomy should be done in selected cases. And all these cases require long-term anticoagulation also. Then anticoagulation in cases of type 1 is controversial. It is to prevent in situ thrombosis. And so it can be used in some of the selected cases. We have various groups of anti-pulmonary hypertension drugs, which acts on the endothelium receptor 1 pathway. We are selecting endothelium receptor antagonists also, like ambrisentan. Then, of course, we have the prostacyclin pathways, where we have got iloprost and epoprost, etc., which are used to increase the levels of prostacyclin. Then we have nitric oxide pathway, cyclic GMP can be increased by using certain drugs, which actually increases the nitric oxide level. And they are the phosphodiesterase inhibitors, like tadalafil, sildenafil, etc. And so these drugs should be used. Then we have a very latest endothelin receptor antagonists, so which have got less hepatic and renal dysfunction, and they can be used with anticoagulants, unlike bosentan, where we have to be careful while using with anticoagulants. So I have tried to cover most aspects of the pulmonary hypertension. I hope my lecture is useful to all of you. And if you have any queries or any thing to add upon, you want to discuss, I should be delighted to answer your questions. Thank you so much. I have finished my presentation. Yes, madam, I have finished my presentation.
Thank you so much, sir. Thank you for your overwhelming talk and for sharing such wonderful insights with our viewers and making them understand about the topic. Thank you so much for that. And we have received a question from our viewer. So I would just put that question up. So the question is, what are the main conditions that should be considered in the different diagnosis of pulmonary hypertension?
Okay. My dear doctors, I think have elaborated great details about the pulmonary hypertension, the various causes of pulmonary hypertension. Unfortunately, we do not have a detailed epidemiological studies. What is the most important cause of pulmonary hypertension in Indian setting or in a global setting? Most of the studies are confined to some of the advanced countries. They have, the French registry. Then we have a European registry, and in European registry, they found that the 50% of the cases are due to connective tissue disorders. And among the connective tissue disorders is basically the scleroderma, the most important one. I gave you that bar chart, in which I showed that 39% of the cases are idiopathic varieties. Then we have connective tissue disorders. Then we have drugs, the various appetite suppressant drugs, drug addicts, which can, with amphetamine use and also cocaine use, which can lead to pulmonary hypertension. In those people who use bush tea and all, we know occlusive disease can occur in some of the cases. In certain select areas, selected endemic areas, we can have. Okay. Then HIV, where HIV is very high, the pulmonary hypertension could be HIV. Schistosomiasis in certain areas, in Mediterranean area, it could be the commonest cause there in those areas. Then, of course, if you have a cirrhosis of liver, portal hypertension, which could be a contributing factor for the pulmonary hypertension. Then, if you have a large number of chronic infected cases, they can develop pulmonary hypertension. So, then hereditary disorders, metabolic disorders. In those cases, the pulmonary hypertension is because of those disorders. So, COPD is very common condition. who have advanced COPD, they can develop pulmonary hypertension. Sleep apnea, I told you, about 8 to 15% can have mild to moderate pulmonary hypertension. So then pulmonary thromboembolism can contribute to 0.5 to 6%. So keep all the possibilities in mind. But when a female comes 20 to 40 with the pulmonary hypertension, we have done echocardiography, we have done, it shows pulmonary hypertension, there is no heart disease, etc. Okay, then think of these conditions, as I told you, COPD, sleep apnea syndromes, then hormonal disorders, then think of drugs. All these things should be taken into consideration. So there is no definitive figures that this is the exact number that you're going to have. It all depends upon the geography. It depends upon the registry which is being maintained. So I hope I have answered your question, but keep all these possibilities. Think of the common conditions when you are in your clinical practice, which is responsible for the pulmonary hypertension. But most important thing is suspect pulmonary hypertension. And the hallmark feature is that they have unexplained dyspnea and right heart failure, unexplained breathlessness, progressive breathlessness. So remember those four class 4 symptoms, NYHA, New York Heart Association, and WHO classification, who become symptomatic on mild exertion or at rest, that is class 4 symptoms. And these are the one. Think of all these possibilities. Suspect pulmonary hypertension, get an echocardiography done, and then investigate all these possibilities. I told you group 1, group 2, group 3, group 4. Group 1, you'll know the idiopathic variety, then veno-occlusive diseases, HIV, schistosomiasis, hereditary disorders, portal hypertension. Okay, so these things, toxins, appetite suppressants, keep all these things. Group 2, heart failure with normal ejection fraction, with decreased ejection fraction, diastolic heart failure, systolic heart failure, valvular heart disease. It's a large group. Okay, group 3, we have COPD, commonest, ILDs, then sleep disorders. There's those in endemic areas like high altitude. So think of high altitude induced pulmonary hypertension. Group 4, those who have recurrent pulmonary thromboembolism or the posterior thromboembolism. There's a risk factor for thromboembolism. So think of group 4. Group 5, when you're not able to explain anything, then think of portal hypertension, renal failure, then the thyroid disorders, Gardner's disease, and all those things. Think of rare possibilities. So think connective tissue disorders. Never forget connective tissue disorders, scleroderma. Never forget COPD. Never forget OSA. And then never forget the heart conditions, heart failures, etc. Okay. Then never forget pulmonary thromboembolism. Okay. Keep these things in mind. I'm sure you will be able to make the spot diagnosis, the cause of pulmonary hypertension. If you have understood my lecture and have taken the proper history, examined in great detail, I'm sure you will be able to come to a definitive conclusion, whether it's group 1, group 2, group 3, or group 4, or group 5. Yes, madam.
Thank you so much, sir. Thank you for elaborating the answer and for making our viewers understand about it in such a beautiful way. Thank you so much, sir, for explaining it. And moving ahead with this, thank you to all our viewers for their ardent participation. We hope that the lecture was useful to you and you have adhered the information shared by sir with his beautiful PPT presentation, the knowledge that he has imparted among all of us. Thank you so much for staying here with us, for staying tuned throughout the session, for putting across your question, and for making us a beautiful webinar to attend. Thank you so much. And I would like to thank you, sir, for taking out your valuable time and for being here at our platform and sharing such wonderful insights with all our viewers here present. Thank you so much for that, sir. So before we conclude, sir, any last comment from your end?
Thank you. It is well conducted. And so I enjoyed talking to the audience. I hope they enjoyed my talk. Thank you.
Thank you so much, sir. So with this, we are concluding the session here for today. Until next time. Thank you, sir.
Okay.